Hi, this is Tal Lee, Senior Editor for First Aid for the Useless Step 1. In this section, we'll cover respiratory pharmacology. We had really chunky talks for respiratory physiology and pathology, but this should be significantly faster. H1 blockers are reversible inhibitors of the H1 histamine receptors and are generally used in the treatment of allergies. There are two generations of histamine blockers, and they can be remembered based on their sedating properties. Remember that the newer second-generation histamine blockers are typically less sedating. First-generation histamine blockers include diphenhydramine and chlorpheniramine. These drugs are used to treat allergies, allergic rhinitis, acute urticaria or hives, and motion sickness, and can be used for sleep. Side effects besides sedation include anti-muscarinic side effects, which includes what? Well, urinary retention and delirium, among others, and anti-alpha-adrenergic side effects like hypotension and dizziness. So these drugs should be used with caution in older folks. Second-generation antihistamines include loratadine, fexofenadine, desloratadine, and cetirizine. As you may be aware, the majority of these are now over-the-counter medications. Like first-generation antihistamines, they can be used to treat allergies and also chronic hives. These drugs have less sedation than the first-generation antihistamines because of what? Because they have less penetration into the CNS. There are numerous classes of medications used to treat asthma, which truly could be a series of lectures by itself. However, understanding the basic underlying pathology involved in asthma exacerbations, as well as the mechanisms of the various drugs used to prevent and treat asthma, should make remembering these medications a little easier. In fact, this diagram over here is an excellent framework for understanding the asthma drugs that we'll be discussing. It all starts off with allergy or respiratory trigger avoidance. Further along the pathway, you can try to prevent the release of mediators with cromolyn and to some extent steroids. Then we'll be talking about a number of drugs that work as bronchodilators here in the early phase response. You'll see that the bronchodilators work through a variety of mechanisms that are illustrated over here. And then there are the steroids and anti-leukotrienes, which reduce the late phase inflammatory response. Okay, recall that bronchial constriction is partially mediated by inflammation and sympathetic tone, so it should be no surprise that some asthma medications target each of these pathways. Beta agonists are used during acute asthma exacerbations to relax bronchial smooth muscles through the action at the beta-2 receptor. Albuterol is a beta-2 specific agonist used during acute exacerbations. I'm skipping isoproterenol because it's no longer used for asthma. Salmeterol, as well as formoterol, are longer-acting agents used for asthma control, as opposed to being a rescue medicine. Other than the usual beta agonist side effects of tremor and tachyarrhythmias, what's the one big potential side effect for these long-acting beta agonists? It's that they may lead to worsening of asthma control. The most likely explanation for this is that you still have untreated airway inflammation, which is why long-acting beta agonists should always be used in combination with an inhaled steroid. Based on the mechanism of action of these drugs, can you think of a common medication that might be contraindicated in patients with reactive airway disease? The answer is a beta blocker. So it's typically not a great situation to have both asthma and heart disease. The prototypical methylxanthine is theophylline, which is used to treat both asthma and occasionally COPD. The action of this drug is likely due to its inhibition of phosphodiesterase, thus decreasing cyclic AMP hydrolysis and leading to bronchial dilatation. So what's the downside of this drug? For one, it has a narrow therapeutic index, which can lead to potential cardiotoxicities and neurotoxicities. So this is not the drug of choice if the patient has heart problems. Ipratropium competitively blocks muscarinic receptors and is used to treat COPD, and it can also be used to treat asthma as well. Tiotropium is a newer, longer-acting muscarinic receptor antagonist for COPD, and it mainly acts at the muscarinic M3 receptor. Chromium stabilizes mast cells and prevents them from degranulating. It's important to note that this is a prophylactic agent. It has no role during an acute asthma exacerbation. This is an older medicine with a good safety profile, but it's not that efficacious. So guess what? It's been mostly replaced by inhaled steroids, anti-leukotrienes, and long-acting beta agonists. Steroids like beclomethasone, fluticasone, and budesonide are first-line therapy for persistent asthma and asthma control, especially when patients experience asthma symptoms more than a few times each week. You typically use inhaled steroids for asthma control and oral steroids to treat acute exacerbations that are not reversed with short-acting beta agonists. Then there are the anti-leukotrienes. Xyleuton inhibits the 5-lipooxygenase pathway, which is upstream or downstream from the leukotrienes. It's upstream. So here it is blocking the conversion of arachidonic acid to leukotriene A4, which eventually begets LTC4, LTD4, and E4, which are the products that are thought to be responsible for allergic inflammation, bronchoconstriction, and mucus production. Similarly, montelukast and zafrulukast, which is used less commonly, interfere with the actions of LTC4, D4, and E4 by blocking their binding to what? Cystenyl leukotriene receptor 1. Finally, there's omalizumab. So what is it and how does it work? This is a monoclonal IgG antibody. So remember monoclonal antibody, MAB, it ends with MAB. It ties up soluble IgE so that it can't bind to Fc receptors on what? Mast cells and basophils. So if this is a mast cell here, your Fc receptors would be here, and then IgE would be here and here. So there won't be any binding of antigen, which would cross-link the IgE and then cause the mast cell to degranulate. So omalizumab is kind of like an anti-missile missile, like the Patriot missile system used in the first Gulf War to shoot down Scud missiles. It's used in patients with moderate to severe persistent allergic asthma who failed treatment with inhaled steroids and long-acting beta agonists. Alright, a quick word about expectorants, as this is just moderately high yield. Guafenicin is an expectorant that removes excess sputum. It has no suppression of the cough reflex, unlike preparations containing codeine. N-acetylcysteine is another agent used in patients with a productive cough. What is this? This is an inhaled mucolytic that is used in chronic bronchitis, COPD, and other chronic bronchopulmonary conditions. It's also commonly used with CF patients, but the data there is pretty weak. You can also recall from your musculoskeletal pharm talk that this is the same agent used to treat Tylenol overdose. Bosentan is a relatively new drug occasionally used to treat pulmonary hypertension. Well, how does it work? It works by blocking endothelin A and endothelin B receptors so that they cannot bind endothelin 1, which is an arterial vasoconstrictor, thereby decreasing pulmonary vascular resistance. Another drug used to treat pulmonary hypertension is sildenafil, the famous Viva Viagra pill. So again, how does that work? This drug increases nitric oxide through inhibition of phosphodiesterase, thus leading to pulmonary vascular dilatation. What are some other vasodilating drugs for primary pulmonary hypertension that you might see on the boards? Well, they include calcium channel blockers, nitric oxide itself, and prostacyclin analogs like epoprostenol and iloprost. This is a new first aid topic for 2012. Yes, cough and cold medicines are board testable. Dextromethorphan is a cough suppressant related to opioids that works how? Well, it binds and blocks the N-methyl D-aspartate receptor, which is a calcium ion channel that's critical in memory and learning. Theoretically, in normal doses, it relieves cough from minor throat and bronchial irritation. There is some controversy on whether it's all that effective. In high doses, it can cause dissociative hallucinations and therefore has some abuse potential. Pseudoephedrine and phenylephrine are also commonly used in cold and allergy over-the-counter drugs as nasal decongestants. They basically act as alpha-adrenergic vasoconstrictors. so you get less nasal tissue swelling and congestion. In addition to hypertension, tachycardia, palpitations, and stimulant side effects, what else do you have to worry about? Recreation drug abuse, since pseudoephedrine but not phenylephrine can easily be reduced to methamphetamines in a backwoods meth lab, which we see all too often in Kentucky. Methacholine is also new in first aid for 2012. It's a non-selective muscarinic receptor agonist that really has no practical therapeutic use. However, we do use methacholine to diagnose bronchial hyperresponsiveness, which we see in asthma, and to a lesser extent in COPD. In the respiratory pathology talks, I didn't talk much about asthma diagnosis beyond pulmonary function testing, but how are the results of a methacholine bronchial challenge test helpful? Well, the test is pretty sensitive. Remember the mnemonic SNOUT from the epidemiology talks? So if the test is negative, it essentially rules out asthma, but here it's not very specific. The mnemonic here is SPIN. That is, a specific test is good for ruling something in. So here, if it's positive, then yeah, it may help you make the diagnosis of asthma with the right clinical context. But you have to worry about false positives, because other conditions can give you a positive test like smoking, upper respiratory infections, allergic rhinitis, and gastroesophageal reflux disease.